All right. Well, welcome back, everyone. We are here with Dr. Jim deMaine for our weekly session, Ask the Doctor. We've got a very important topic today, and I know that many of you will be watching this as the replay of the video. Welcome to the video as well, because we are talking today about medical aid in dying, which has many different names and things that is called. Some people call it with death with dignity. And then there's a variety of other ways of describing assisting somebody in the dying process. And it is a very controversial issue and a very important one. And so with that, and you can start filling the Q&A up with questions whenever you want. But with that, I'm going to turn it over to my friend Jim. Welcome back, Dr. Jim.
Oh, thanks a lot, Michael, and thanks for anybody watching this. In Seattle, it's a very warm day, so I understand probably why a lot of people are not sitting inside, but outside enjoying the weather and life as it is after COVID now. But this issue has been raised in a couple of the prior sessions we've had, and I think it's a very important one. About a quarter of the US population is now living in states that allow medical aid in dying. This has been called assisted suicide by the opponents, death with dignity, or medical aid in dying by those who generally support it. And it's divided the population, although when the laws first came into being in Oregon, legislators did not want to touch this. So it passed by voter initiative in the state of Oregon, and then again in the state of Washington in 2008 and enacted in 2009. And then since a number of other states and Washington, DC, it's really a total of 11 jurisdictions now that have medical aid in dying. The biggest joiner, or the biggest law that was passed was in California, 2016. And they have been very active in organizing the thinking for clinicians about what process you need to go through, also how to support patients and how to support others that are involved in this whole field. And I'd like to refer you all to a website. It's called American Clinicians Academy on Medical Aid in Dying, or it's acamaid.org. And it has videos, it has instructions, it has controversies, has support for clinicians, support for patients, resources. And it's there's a listserv for providers headed up by a physician that specializes in this area in California named Lonnie Shavelson, who's done a marvelous job of bringing clinicians together, getting dialogue going on across the country about the ethics of this, about controversies, about medications, about support, and the whole field. What I'd like to start off with is just read you a little bit from my book called Facing Death, which I actually wrote during the COVID period, so I had time to think more about this. So here it goes, death with dignity or medical aid in dying. Over the past year, 4 acquaintances of mine have ingested lethal doses of medication obtained through a doctor's prescription in order to control their last moments. 3 had cancer and 1 had ALS, Lou Gehrig's disease. I was not involved in their medical care, nor as an advisor. Irene's family was open about her choice. She was 90, frail, and very tired. The diagnosis was an acute form of leukemia. I'm not interested in chemotherapy, said Irene. Just let me go quickly. After she was gone, Irene's family held an open meeting at the care facility where she had passed away. 90 friends and acquaintances attended. The family spoke of her wish for medical aid in dying and want others to know that she had had a peaceful end to her life. 88-year-old Gordon called me to say goodbye the night before he ended his life. He had advanced pancreatic cancer and had been living with the drainage tube placed in his destroyed gallbladder. He couldn't get comfortable even with the help of hospice and palliative care. He couldn't get comfortable. Sleeping was all but impossible. A scientist by training, Gordon wanted control at the end of his life. His doctor helped him obtain the medication, and a nurse friend helped him mix it. With the family present, Gordon sat in his living room, drank the medication, and within minutes was gone. Matt was a retired pathologist. He didn't realize he had advanced prostate cancer until it spread to his spine, causing paralysis. He was told he likely had less than 6 months to live, and he didn't like the idea of spending that much time in a nursing home as the cancer spread. I was called in to witness his signature on the necessary forms, and the nursing home did not object because Matt did what is lawful in the state of Washington. He died peacefully. The fourth one I know is Nancy. She had advanced ALS, Lou Gehrig's disease. She suffered progressive weakness and difficulty with speech and swallowing. She began to have aspiration pneumonia because she couldn't swallow properly. And she felt she was suffocating. She did not want a tracheotomy or a feeding tube. Nancy's family was very private, so the details of her death were really not known to me or widely known, but it's likely that it occurred in her vacation home. Her husband simply told me, now she's at peace. I offer these 4 real-life examples to present the kind of scenarios in which medical aid in dying laws are used. I'm going to skip over a little bit of this. All these laws are similar. If a person is confirmed to have less than 6 months to live, their physician may order oral medications to end their lives. There must be a written request by the person, a waiting period, and a mental health assessment if there's any question. More importantly, the patient must administer the lethal medication to himself or herself. No one may assist. Initially, though, I had some concerns when these laws were passing about the potential abuse of these so-called death with dignity laws. As more of us reach advanced age and the pressure to conserve health resources mounts, we need to ensure that individuals are making autonomous, well-informed choices, not being pressured by some external cost-saving measures. We also need to ensure that affordable health care, plus superb hospice and palliative care are available to these very ill people. Currently, only about 1 in 400 deaths in Washington state occur via the medical aid in dying route. In my practice, I care for many patients at the end, few of whom ever invoked this option. Instead, I saw more terminally ill patients referred to hospice, fewer hospital deaths, and more comfort for patient and their loved ones at home. Often that is the greatest wish. So despite my worries, the death with dignity laws ironically seem to have made the medical and nursing professions step up to provide more sensitive end-of-life care than we saw in the past. Is the name too euphemistic? Actually, it's called death with dignity because that was the initial name of the law that was passed in Oregon. More recently, the term medical aid in dying has been the general term used. But does death with dignity imply that other kinds of deaths are undignified? Those who oppose the DWD acts call them physician-assisted suicide, and the Catholic Church has been particularly resistant, as have other conservative religions, perceiving that these laws are evidence of a culture of death in our society. Some believe that suffering is redemptive and that we should not interfere with the life force in any way, a position that must be acknowledged. These are sensitive issues, and agreement around them will not disappear anytime soon. Either way, death with dignity could be more accurately described as patient choice in dying. Certainly, that would be more realistic. But now it's medical aid in dying, and that's also what they call it in Canada, which has liberalized its laws around end-of-life decisions, much like we see in some European countries, particularly the Netherlands, Belgium, and Switzerland. In Canada, the MAID laws now allow physicians to directly administer lethal drugs. They don't need to be self-administered, either orally or they can give intravenous medications to hasten death in certain patients diagnosed with grievous and irremediable conditions, not necessarily less than 6 months to live. The other crucial difference compared to our laws is that there is no requirement for a person to necessarily have a terminal prognosis of 6 months or less. These laws are gradually being implemented, and there still is court controversy going on in Canada, as you might imagine. The overall question is, should there be limits on our autonomy to choose? We believe in self-determination in medicine, and the laws around advanced directives are embedded in the Self-Determination Act. Controversy around this question has even spilled over to the use of advanced directives, some suggesting that such planning is tantamount to a death panel. It's my hope, though, however, that the ethics around an individual's right to choose what is done to his or her own body continues to inform our laws. So, Michael, I think I'll stop there. There's probably plenty of questions that people have, and also you're close to this issue, I know.
Yeah, just a reminder to people, if those that are viewing live, you can go ahead and use the Q&A function if you have questions for Jim. My first set of questions really about just clarity. There used to be a term that was thrown around, which is euthanasia. And there was this notion of a big long needle being administered. And so there have been some, and I think the word euthanasia and this idea of it being a painful process comes up. So some clarity there. And then I don't know if it's different state by state, but if there is the general pathway, what is the experience like for the patient? What is it that they're taking? How long does it tend to impact? And then, what do we think that it's a painful experience, or do we know that it's not a painful experience? So there's a few questions there to unpack.
Well, as you might know, it doesn't always go well. And actually, I got an email this morning about some suggested adjustment in the medication regimen that's being given. It's been difficult because the classic drugs, pentobarbital, which comes in a solution and is very effective, was essentially taken off the market. It was made very prohibitively expensive. The drug companies and European imports did not want to be identified with basically what they would call killing people. So pentobarbital disappeared, and that was replaced by Seconal, another common sleeping pill. But that, through various drug companies maneuvered, was raised to a price that is well over $3,000. So that prices a lot of people out of the use of that drug. So they've come up with really now a 5-drug cocktail, and they are now carefully monitoring and reporting how long it takes a person to go to sleep, how long it takes them to pass away, how to monitor them, and then relate the experience. And this is, again, reported out of this American Clinicians Academy for Medical Aid in Dying. The current drug regimen is let me go through it here. It's MMDA with phenobarbital added. I'm sorry, it's DDMA, digitalis, diazepam, which is Valium, morphine, amitriptyline, which is an antidepressant, and now phenobarbital has been added, which has been apparently a very good additive in terms of preventing unwanted outcomes. The an anti-nausea has to be given ahead of time so somebody doesn't vomit. And then the medications mixed and administered. And actually there's videos on the website that I mentioned that are the how-to of all this kind of thing. And actually a physician does not need to be present, but it's good for a hospice or death doula or somebody that's experienced with the use of these medications, mixing them, administering them. And of course you want loved ones and family there, but it helps to have a trained person there for support, because the family is under great duress, as of course is the patient. So the average time to actually death now after the medication is a little over an hour. But of course, people are asleep prior to that, and they can be just watched or monitored with a cardiogram and an oximeter pretty easily, or even just a pulse oximeter, which monitors their pulse and oxygen level. And they're readily available now. And so that's kind of mechanically how it's done. Because these drugs were restricted, and we could hear the stories about capital punishment, and Dr. Kevorkian administered them intravenously, and all the bad press that came up around this. People got the idea that it would be a painful death, but the number of there's one drug that amitriptyline particularly that can cause some burning in the esophagus, but they have a workaround for that now. And the difficulty in this field is they can't do true research. They can't do peer-reviewed research and publish this in major journals. So this is why I like the idea of this academy, which just formed last year in February of 2020 at UC Berkeley, when they had a national conference on medical aid in dying, that this organization formed. It's very new. They're sharing data. Universities are posting questions. Physicians all around the country are posting questions. They want to be involved. They want to help. They want to help make the laws good. So we're still in an infancy in this whole field. In our country, only about in the states that approve it, only about 0.2% of all deaths are death with dignity. And whereas you look at, I think the Netherlands is about 5% of all deaths. So that's a much more liberal country. They allow intravenous medication to be given by the physician at home, things that we are scared away from in this country.
Yeah, no, this is, I think, as much information as people can get around these type of details. I think it's very, very helpful. So thank you for walking through that. Bob Hoffman is back with some questions. Hi, Bob. Bob lives in the DC area where it's legal, but he has indicated that it's difficult to find physicians that will actually administer or do subscribe to the practice. Obviously, Compassion and Choices is the major advocacy group to support these laws. Pretty extraordinary national organization. So Bob's got a controversial question for you on a controversial topic.
Sure.
I don't even know what you call that. But the question is, for those who live in states without death with dignity laws, are there legal sources for getting drugs from sources where the patient can accumulate sufficient drugs to self-administer, for instance, the final exit network?
Yeah, I'm not sure the current activities of the final exit network. They are somewhat off the grid, skirting the edge of the law. I happen to be playing bridge down in San Diego one time, where there still is a Hemlock Society. And I talked to a psychiatrist lady at the bridge table, and we started talking about this. And she said she was flying up to Washington State to be a navigator to help somebody die. And they were actually using nitrogen with a head mask. And it's actually a fairly painless way to go. You have a tank of nitrogen, you have the head mask with a seal, And if you don't have oxygen, you become, as airline pilots or experimental pilots would know, you get up to a high enough altitude, you pass out just from lack of oxygen, and not even know that you're passing out. And that's kind of what the death navigators would do as part of the final exit network. Whether they have channels to obtain medications, I'm not sure. I mean, there's probably always a way to find these. Some people probably try to import them from elsewhere, particularly the barbiturates, which are as a single drug, work just fine, but we just don't have access to pentobarbital or even Seconal at a reasonable price. I don't know if that helps, Bob, but
I think so. I'm going to read a little bit from my book, actually, because I wrote a whole chapter on this topic. And there's a question here, and we're going to talk a little bit about Dr. Ira Byock,
yes.
who is a mentor, a friend of mine, an incredible leader in the end-of-life space. And I'll start reading. Ira Byock is one of the most outspoken detractors of doctor-assisted or medical aid in dying, but he is not a faith-based detractor. He is a non-religious Jewish doctor who in many ways the father of U.S. palliative care. He sees the current hype around death with dignity as missing the point completely. What we are facing, according to Ira, is not a lack of options, but rather a lack of quality care at the end of life. And I'll quote from Ira: "I believe that deliberately ending the lives of ill people represents a socially erosive response to basic human needs. If we can stay civil and even relatively calm, we can debate physician-assisted death or he calls it suicide, while also substantively improving end-of-life care." Any thoughts on Ira's position?
Well, he's certainly revered in the hospice field, and I've talked to him at conferences before. I mentioned him in my book as the opponent also. And in talking to palliative care and hospice people, a number of them are opposed to the death with dignity laws. They feel it's almost a failure in their field if they can't give somebody a good death, short of choosing that option. On the other hand, the people that are choosing this option are an interesting demographic, at least at this point, because they're 96% Caucasian. They're mostly college educated. They're mostly white. And they are people of like an executive mentality. They want control. And they feel they have that right to control their body at the time of death. And for me, it's hard to argue with that. I think he's worried that the concept will spill over and become ageism. If you live to a certain age, you've kind of outlived your usefulness, isn't it? Time, and then you do get erosion or coercion even toward that choice. But at least the laws that they're currently configured are really, really pretty careful and pretty conservative. They were worried about that slippery slope. But on the other hand, you have people like Diane Rehm and others that are very strong proponents of a right to choose. And then, of course, you get into the difficulty in the laws of, well, if you're going to live longer than 6 months, what options do you have? And that may be a subject for a different time, but it's called voluntary stopping eating and drinking. And you always have the right to stop eating and drinking. Nobody can force that on you, perhaps unless you're in Guantanamo Bay. But generally, it has been done. It is being done. There's books written about it. There was an international conference held at Seattle University School of Law. It's interesting, at a Jesuit School of Law, they held this conference about ending your life by stopping eating and drinking. So that is one option. But I would say to Ira that where we're using really aggressive palliative care to the point of making somebody unconscious, and then we just have to wait that period while they're dehydrating till they die. To me, I don't see that much difference between the medical aid in dying. they don't like, hospice people don't like that term just for the death with dignity laws, because they say we provide medical aid in dying all the time. So there is that clash still in terminology. And I think there's good people on both sides.
Yeah, I don't see there being a full agreement anytime soon on whether this law should exist or not.
Yeah.
One thing that I was moved by in my research, and EOL itself stays Switzerland on the topic. We're trying to serve all people, and some people find that this is a very defining decision to be making for people. So um, however, in our Switzerland status, I spent time talking to Anthony Back, who's somebody I know that you know well, who used to be um, against the notion of medical aid in dying, and through being close to it, if I'm representing that correctly, really changed his position to one of advocacy. And one of the reasons being that he found that it allows families and individuals to actually more in a some way sometimes more healthy fashion prepare and embrace the fact that they are going to die, and create some really meaningful ritual
Yeah.
around it, as opposed to the last chapter, last mile, being one of constantly responding to um, you know acute situations. Now, of course, this is only for a certain type of person with a certain type of diagnosis and a certain set of symptoms.
Right. Yeah, and some cultures don't embrace this. Particularly, we're not seeing very many from the African American community or other minority communities thinking about this option. And there's probably a whole host of trust issues that are involved, or religious issues, or just what you mean by death. Is death final, or is it just passing into another existence? So they everybody's going to look at it a bit differently, for sure.
Um, and we just have a comment from Bob that he agrees it's possible to have both top-notch palliative care for the vast majority of cases, and also have an opportunity for death with dignity in rare cases when appropriate.
I might say, in big cities where you have a number of providers, it might be easier to find somebody, but there is a physician I've been in contact with in the state of Washington that says, he's in a smaller town, and it's just hard to find people to line up to be willing to participate in this. So we have, I think, a lot of work to do within the medical profession to bring physicians on board and make it more rewarding for them to have this be part of their life. And if you get into rural Washington, for example, I was at a conference and asked physicians to, give me your stories so I can put them on my blog. And one fellow wrote me a story about a death with dignity or medical aid in dying situation he had in his small town, but he said, I can't put my name on it because I care for so many people that are dead set against this. And it almost appears like a conflict of interest. So it flies under the radar. And I think it's true in palliative care as well. And hospice also can be of some distance. So it's a little bit more difficult to make these accessible in smaller communities.
Yeah, and I think what is really important, and compassion and choices is a great organization.
Yes.
Also underscoring the word compassion and empathy. We don't know why somebody might be against these laws unless we get very, very curious. And as you mentioned, there are some parts of our culture that have been deeply underserved by our healthcare system. Right. And don't have a reason to trust it. And then there are people who have very deep religious beliefs or spiritual beliefs,
right.
And are answering to something, beyond just the politics of the day. And so, as much as whatever side we're on this, that there are some very meaningful reasons to hold these.
I think if you get close to this and you really see it, the people that choose it, like Anthony Beck did, it will begin to change the way you feel about it. And this is what happened in the Vermont legislature was the first one to pass this as a legislative law. And that is because one of their own revered legislators was dying a severely painful death. Things were not under control, and he had managed to obtain a supply of medication, I'm not sure, and was planning his death. But it was illegal for his wife to be in the room with him because she would be an accomplice. Nobody could be with him as he ingested this medication. And all the legislators knew him, and they knew what was going on, and they said, this is ridiculous. We need to pass a law. So they got close to it. It was one of their own, and that's why that law was passed.
Yeah, no, that's great context. Incredible work has been done in Washington too. End of Life Washington is a remarkable organization and one of the pioneers.
For sure.
We're out of time. And to answer your question, Joanne, from Oxford, Mississippi, my name is Michael Hebb, and I'm the founder of Death Over Dinner and EOL.community, which hosts these weekly chats. And this is my book. It's Let's Talk About Death Over Dinner. So thanks for asking. And that wasn't just a plug, there was a question. And we'll see. Once again, Jim, thank you. And we'll see you next week. For those that are tuning in regularly, we're going to continue these up till early July, take a little bit of a summer break, and be back in September. So you've got a few more sessions before we say goodbye for our summer break.
Right, I think July 6th, and then we'll go on a summer break. So yeah, looking forward to that too.
All right. Thank you, everyone.
Okay, thank you.
Sweet.